Hello and welcome to the latest in our series of NR Times roundtable discussions. And today we're focusing on the critically important subject of child brain injuries and rebuilding lives after child brain injuries. I'm delighted to say that we've got a fabulous panel with us today who are more than willing to share their experience and understanding and insight of this important topic. So to start the discussion, I'm going to ask everybody to introduce themselves, but before I do so, I'd just like to say a really big thank you to the sponsors and supporters of this discussion today. Irwin Mitchell, without whom this discussion wouldn't be possible. So thank you to the whole team at Irwin Mitchell. So we're going to go round our panellists who will say a few words about themselves, their organisations and their areas of specific interest, and then we'll move into the wider discussion. So if I could start with you, Joe, and ask you to introduce yourself, please.
Yeah, so my name's Jo Bamberger. I'm a case manager for the Child Brain Injury Rehabilitation Service. I've been case managing for, 5 or 6 years now, working predominantly with children with acquired brain injury. I have a couple of adults that have snuck in there as well, 1 or 2 because they've just simply got older. So the company I work for, we do predominantly case management for children and adults with brain injury and other significant injuries. My background is I've been a social worker for far too many years, mainly in the area of children with disabilities. So I'm coming from an area of working with families, with children with quite severe disabilities, with a social work head on. So that's a little bit about me and where I come from and what I do.
Fabulous. Thanks for kicking things off, Joe. And Carmel from Irwin Mitchell.
Good morning, everybody, and thank you, Alistair. Yes, my name is Carmel Gallagher. I am team leader for the Support and Rehabilitation Service here at Irwin Mitchell. We are a national multidisciplinary team made up of clinicians and non-clinical professionals, so therapists, nurses, social workers and teachers, and we support clients alongside the litigation process, most commonly in the early days post-injury. My background is in residential childcare. I do apologise, there is an alarm going off in the room.
Hi everyone, so my name's Emily Bennett. I'm a consultant clinical psychologist and paediatric neuropsychologist. I work at the Nottingham Children's Hospital in the Children's Neuro Rehab team, which is known as the BRIL team. It stands for Brain Injury Living Life. And I'm also the chair for the Enables, which is the National Acquired Brain Injury in Learning and Education Syndicate, which is part of UCBIF. So it's nice to be here today. Thanks.
Jan, can we come to you next?
Good morning, everyone. My name is Jan Rock, and I'm the founder of Matrix Neurological. I'm a brain injury mum. I had to rehabilitate my own son following a severe brain injury and discharge from hospital. And Matrix was founded to bring lived experience to this whole field, if you like, and lead what is delivered to families. So we connect with families in a very different way. It is through lived experience, rather than we're all from professional backgrounds, but not in healthcare at all. So we have a very different approach, and we bring a lot of different skills to neuro rehab that work.
Great, thanks for that, Jan. And I hope maybe during the course of the discussion, we'll be able to hear about some of those very direct and personal experiences that you've had. And last but not least, Kay, if we can come to you for an introduction.
Yes, thank you, Alistair. Good morning, everyone. My name is Kay Ganguly. I am a consultant physiotherapist, and I'm also an expert witness. And I'm the clinical lead and the director here at Healing Touch Rehab. We are a multidisciplinary team, primarily community-based, within Yorkshire, but also we cover a large area. And a team of physiotherapists, occupational therapists, and speech and language therapists. And we particularly work with people, individuals who are neurologically compromised, whether pediatric and adults as well. And my specialty and interest is primarily in pediatric neuro rehab, particularly with children with acquired brain injury, something I'm extremely passionate about. So I'm really looking forward to having this open conversation with you all. Yeah, thank you for having me today.
Great, thanks very much, Kay. I'd like to open the discussion by asking each of our panelists to say a little bit about what they think excellence looks like with reference to care, support and rehabilitation for the kind of injuries in children that we're talking about. Just before I do, I should say that Carmel from Irwin Mitchell may rejoin us and may not, because she has had to evacuate her building. But if Carmel doesn't rejoin us, we'll ask her maybe to address some of these comments and add it on to the clips that we put onto YouTube over the course of the next day or so. So, Joe, if I can come to you and ask you about your view about the things that are really critical to making sure that care, support, rehabilitation is excellent in every sense.
So the main thing that I have with all of my families is a real concern from them that they've entered this rehabilitation litigation area and they suddenly become massively overwhelmed with a whole load of appointments. They've got the expert appointments, they've got the rehabilitation appointments, they're fighting often the school system and this whole raft of issues that suddenly descend upon the families who I work with, and they find themselves often just in the middle of this mire of stuff, not really knowing where to turn to and unable to cope with. Yes, they've been told that if they go into this system they'll get support and help, but suddenly they've got 1,001 things, no time to do them. So for me, from a case management perspective, excellence starts with making sure that we make things manageable for our young people and their families, that we don't suddenly make them do 1,000 things, that they've still got time to be the mum, the dad, the sister, the brother, and that their young person has got time to be a child and to live as close as possible the life that they were living before, that they want to go on and live. So I'm sure we'll probably hear from a lot of other people about the various therapies and supports that we can put in, and they're absolutely vital. But for me, the whole thing revolves around working with the family so that we can do an add-on to their life and make it a good life rather than making it a life of therapy and support. I've got a number of families who have said to me, I think if I had £1 for every family who said to me, I wish I'd never started this, I'd be a very rich person, because my families suddenly find that they haven't got time to be themselves. So what I try and do as best as I can in the case management is sit with them and say, actually, where would we ideally like to get to? But actually then within the scope of what you can manage and what's going to be helpful for you as a family, how do we take that in our bite-sized chunks and get it to the point that actually we can get the rehabilitation in, but that it's helpful rather than a hindrance.
Great, thanks, Joe. And I'm sure we'll come back to some of those challenges of balancing the fact that the normal day-to-day demands of life go on along with the demands of providing care and support and rehabilitation. Emily, can we come to you next and maybe hear your thoughts on excellence and those critical factors?
Yeah, sure. And I completely agree with Joe. I think, all of a sudden families are launched, aren't they, into a world that often they're really unfamiliar with, and that can be hugely overwhelming. So I think some of the points that I would be making around excellence is thinking about that sort of support that wraps around them. I think it's hugely important. We've got multidisciplinary teams supporting families and, each having their input into the different areas of challenge, which we know exist after ABI. I think as well, what's often missing, certainly within the NHS, but kind of in other settings as well, is that sense of, acquired brain injuries can look different across development, and we need to be responsive across the whole developmental period to those changes in need and to the way the ABI might evolve for that child. So, you know, seeing rehab as a long-term occupation is really important, and having services across the board that support that and feed into that is really crucial. I think what we're lacking in a lot of areas as well is a system or systems around children, such as education, that don't fully understand what an acquired brain injury is and means. And I think that educating those systems is really crucial, because if we're sending children back to schools who just don't understand acquired brain injury, you know, we're starting from quite a poor point. And I think, you know, within that, we need to be then developing those pathways back from hospital, back to community, into education, and further on through rehab, so that, you know, patients and families know what to expect. They get something consistent in different parts of the country, which doesn't happen at the moment. And then we're really making families feel supported so that they can go and live their lives as much as they want to and can do, but within a context where they feel fully supported.
Thanks, Emily. That does seem a fundamental point around education and awareness and understanding. Thanks, Emily. Jan, your thoughts?
Excellence for me is about empowering parents. And as a parent myself, at the point of discharge, you are being set up to fail, because nobody explains your child's brain injury to you, and nobody even tells families what might emerge in the future. So they're just left looking into blank space now, and not really knowing what to expect. Now, just to pick up on what Dr. Emily has said, a lot of the families we deal with, and we are here for families that don't have a legal case, where these kids get nothing, absolutely nothing from the NHS, and end up in CAMS, and it turns into a nightmare. And CAMS don't understand this either. But just picking up on what Dr. Emily said, you can educate schools as much as you want. You've been trying to do that for the last 30 years, and schools don't want to know. And what they will say is, one, we don't have time. Two, we are not experts in brain injury, and we're not here to do neuro rehab. We're here to educate children. And that is the biggest issue. So what everybody is facing is barriers and a lack of knowledge and expertise. Now, what we see is, you know, and this is no, it's not meant to be negative towards Joe, but we deal with, there's a lot of professionals involved with children with brain injuries who haven't got a clue what they're doing. And some of our kids that we work with have been under the care of up to 35 professionals. And what they're saying to us is, I wish I was dead. I wish I'd died when I had my stroke, because nobody really understands it. And that's the issue. And even with mental health professionals across a range of different professionals. And what we find is up to 10 years after a brain injury, that child will still have the same cognitive impairments as they did when they were first diagnosed, or they had their very first assessment. And this could be 10 years on. So the whole assumption that children get neuro rehab at school is a myth, because what the kids tell us, and we are now dealing with we work with children and young people up to the age of 25. And what those kids are saying to us is, it hasn't worked at school. I still have the same problems. My memory is still really poor. That then leads to Job Centre Plus, who we also engage with, who are then saying, Jan, what do we do with them all? They can't tell the time. They've got no memory skills. Their memory doesn't function. So the current system has to change radically, because all we're doing is consigning children to a lifetime on benefits.
Okay, I'm going to come to Kay next, but just before I do, Emily, you clearly want to come back on something there, so I'll give you the chance to do that before we go to Kay.
Thank you. I think you know, I can completely agree with you, Jan, and I think for some young people, absolutely, their picture is not a positive one, and they do experience significant challenges and a lack of support across their kind of whole development, and it's really challenging. However, I would also say, I work really regularly with schools, and I don't think teachers don't want to help. I don't think schools are saying we're not doing any rehab. They try hard. They've got a lot that they're responsible for, and they've got a lot going on. But actually, we get really positive engagement from schools who want to do things differently. There's a big drive for differentiation and for sort of understanding quality first teaching. And a lot of the needs that young people after certain types of brain injury have are met really well within that context. They just need to understand brain injury and to know about the fatigue and all of the other challenges that young people are experiencing to be able to help them. We're not asking them to fix the memory problems. That's very unlikely to happen within a school context, but they can support them with compensating. And I think that that's important. I agree with you, it doesn't always happen, but that shouldn't mean that we're not trying to make that the case.
Thanks, Emily. I know you want to come back in, Jan, and we'll maybe come back to that because clearly there's a difference of experience in that you've been dealing with, Jan, and you, Emily. So we'll maybe come back to that when we talk about challenges. But I'm keen to bring in Kay just to round off our panelists talking about excellence and the critical factors in that. Kay?
Yeah, thank you. For me, excellence is early intervention. So particularly with our pediatric population, as Emily mentioned, neurodevelopment and the growth and development plays a significant role. We have got a small window to make these children thrive till they reach their, full maturity at the age of, 17, 18 or whatever age of skeletal maturity. We, from a physiotherapy point of view, we have that window to make sure that we are working with these children, early intervention, and helping them attain their optimal outcome. Quite often, by the time we are instructed, obviously we are independent practice. By the time we are instructed, we have the child being discharged from the hospital. There's been a gap in rehabilitation, and by the time we are involved, we can still work on those areas, but we have kind of missed a few years, say, for example, where the child has not had much intervention. And that can have a little impact in the long term. The earlier, the better outcome and the better neuroplasticity. So for me, early intervention is absolutely the key. The other thing as well is cohesive and collaborative working, whether it is with the educational setup, whether it's interdisciplinary within the team, physiotherapist, occupational therapist, neuropsychologist, speech and language therapist, we all got to put in the work together. And it's a very collective approach that really works. And then building awareness with the school educational setup. And I agree with you, Emily. The school authorities, they of course want to do the best within their remit. But unfortunately, they are not always well equipped with the knowledge which we are there to offer, and they are quite often short-staffed. EHCP and the funding is quite a big challenge, as we know, and unless they have the funding, they cannot have the staffing. And staffing is required because a child's rehab is not just limited to home; it's limited to school. It's basically to everywhere where they live their life and where the majority part of their week they spend. So I think it's a very, very collective approach that we got to think together. But these are the foundation of excellence, I think, if we want to make a child thrive.
Thanks, Kay. That's really helpful. I do want to come on to talk about all of those things that are going to make positive differences to care and support and rehabilitation. But before that, we should probably bottom out some of these challenges, particularly for the families and those supporting those that suffer with injuries. And Jan, I could see that you were twitching to come in there when Kay and Emily were speaking. So maybe we could start with you. It seems to me that we've touched on a number of challenges: money, having joined up care, awareness and communication. Again, I'd like to go around the panel and just say a little bit more about the key challenges for families and those supporting families. But I'll start with you, Jan, since you were keen to come in there. Thanks, Jan. Well, that's a really direct and striking sort of manifesto for radical change to things as they are at the moment. It'll be interesting to hear what other panelists think. Emily, do you want to come back on that? Again, the original question was about challenges in the widest sense facing families and those offering support, from financial through to maybe some of the more practical questions.
Yeah, so I think my first kind of just response to Dan there would be, I don't know your work kind of directly, but I would imagine the families that you do see perhaps are those that are having challenges. So my team supports every child who comes into the Nottingham Children's Hospital with an acquired brain injury. And some of those, absolutely, we have ongoing challenges. It is very difficult for them, and the return to school is incredibly tricky. I completely agree with you. However, we also have a large number of our patients who their primary goal is to get back to school. They want to be with their friends, they want to be back with their teachers who they know, and they want the security of that structure and that environment. And it's a different, unfamiliar in some ways environment for them, but it's also familiar. So for some of our patients, the best thing we can do is get them back to school as soon as possible. And they do want that, and they do well within that context. I think perhaps you tend to see those that are struggling and that are having difficulties with that system. And I'm in no way suggesting that those don't exist. I completely agree with you. I worry about those families very much because, as you say, there aren't the pathways that there should be within statutory services. I work primarily in the NHS, and I have done for the last 15 years. And we are working nationally every single day to try and make this better. We've got service specifications coming out around neuro rehab in the coming months, which we hope will improve things. But it is patchy and it's a complete postcode lottery at the moment what children get from statutory services. So it is incredibly challenging. I think the other point that I'd make really quickly is we did a service evaluation for our patients about a couple of years ago. And we did look at kind of, what needs parents were reporting after acquired brain injury. And I completely agree with you. They were all saying we need to learn to advocate for our children, and that is really difficult because there's this huge shift. We're adjusting to this new normal, and we're trying to make sense of a world that we're navigating that we just didn't know. Many of them don't know the SEND system. They've had to learn all of these things. And very much within my service, we are thinking all the time about how we can upskill parents and help them to be able to take on those challenges. We run parent support groups and so on so that they learn about these things and can hopefully move them forwards. However, my worry with putting all of that expectation on parents is that there are some families where they just can't do that for lots of reasons, particularly those from socioeconomically deprived areas, particularly those who may have English as a second language or other sort of issues that may get in the way. And I think we have to then have systems and pathways in place that mean that professionals can support around that. I'm not suggesting professionals are the experts and know everything at all, but I think we have got to give that wraparound support, particularly for those hard to reach families, those families who cannot do that advocating for themselves.
Great, thanks for that, Emily. I'm going to come to Joe and Kay in a second to follow through in challenges, but Carmel, great to have you back with us again. Would you like to just say a few words of introduction? Everybody else has also said a little bit about what they think excellence looks like, and then maybe any views you have on challenges that families and those providing support have to deal with. So you can catch up with us.
Thank you, Alistair. Well, at least everybody now knows that it's definitely a live webinar, don't they? If you have to evacuate the building before you get started. Really great to kind of come in at that point, actually. I think picking up on what both Jan and Emily were saying, I work as part of the support and rehabilitation service here at Owen Mitchell. And as I started to say earlier, we are a national team and we're looking at providing support in the very early days for families who've been impacted by traumatic injury, including childhood brain injury. And I think, as a team of professionals and as a body, we've talked for a long time about the ripple effect in families, and I think that actually does a great disservice and minimizes actually what we're talking about, because it's not a ripple effect, it's a seismic shift. It's like there has been an earthquake, and the aftershocks of that experience are felt by families throughout their lifetime. And those aftershocks might be because of new diagnoses coming further down the line. It might be to do with coming to the realization around a child's particular needs. I don't know whether it was touched upon whilst I was out of the room, but there's that huge aspect around transitions into adulthood and the brand new challenges that they can bring for families. And I think that impact on the family, for me, cannot ever be underestimated, because we're talking about families who have been traumatized, who are exhausted, who are confused, and now, in the midst of all of that, are expected to also be full-time therapists delivering highly skilled, highly bespoke, personalized rehabilitation. And I think for me, it's really important that we think about the child in the context of their own individual family network, and that we don't make assumptions that any parent or any parent carer can or will just kind of do it. We're asking so much of these families, and what we really need to be focusing on is making sure that the packages of support, the packages of care that are put in place better reflect the needs of the whole family, including parents, carers, siblings, and that wider social network that the child exists within.
Great contribution. Thanks, Carmel. Jo, thoughts on the challenges that you're facing and how they...
Yeah, so I think I've had a foot in the statutory system and now in the private system, and many of the challenges actually are similar for both. And yes, sometimes you may have more money and more resources. It doesn't always, unfortunately, solve the problems. When you get your young person who first has their brain injury, especially if it's an older child as opposed to a birth injury, because then you've had your life before and suddenly this is different. But for any children with birth injuries, I think Jan mentioned before that the parents need to know actually what their child is going to be like in going into the future. We often have the Child Brain Injury Trust, CBIT, going into the hospitals and having those initial conversations with the family to tell them about brain injury and what happens. But at the time, the parents are shell-shocked. Their children have just had this massive brain injury. Their lives have been turned upside down. And no matter how much you give a parent information at that early stage, the likelihood, if it was me, I wouldn't be remembering all of that. I would need to be told that again and again, and to have it drip fed into me as time goes on, and to have it specified for my child as that child develops. So what might be true for Carmel's child or Emily's child will be very different to my child. So one of the challenges is finding the professionals, and maybe having one or two lead professionals rather than 1,000 different people, to work with our families to say, actually, this is your child, this is how they're developing, this is what they now need, this is what's going to happen in the future, to go on over a longer period of time. As you get your child coming out of hospital, you suddenly find that maybe you've got carers in, you've got equipment in, you might have a hospital bed, you might be into hoists or commodes or any other manner of things. And regardless of whether you've got additional funding coming in from the insurance and the litigation or not, you've suddenly got a whole load of extra things into what's a house that isn't geared up for those. You haven't got space for all of these things. You're falling over yourself. You may have extra carers and therapists coming in. Again, you haven't got the time and the space to have those. And a family's life can be really turned upside down. And the more that me as a private provider throws at these families, actually the harder it can be sometimes. I sometimes think I'm at risk of making things worse for them, because I'm chucking in carers, I'm chucking in rehab assistants and physios and equipment, and they just haven't got the space. So regardless of which side of the financial divide really you're on, the issues are the same. You need time, you need space, you need time to take this on board, as well as all the issues that were touched on earlier about the appropriate resources going into the schools, into the home. You need to be able to work with the families to facilitate the space, the time, the knowledge, the long-term understanding and for them to be able to work out actually their child was this child over here. Yeah, they were, James or Jim or whatever the child is, that was their child. Actually, their child is now a different person. They've had a brain injury. Often it changes their personality significantly. They might become angry, they might become forgetful, they might have all of these challenges, disinhibited, and actually getting to know that child as they are and to find the positives in that. I remember one of my young people, she'd become quite disinhibited. She'd been a really, really quiet and shy child at school. She has her brain injury. She was about 14 or 15. She said, actually, I'm really cheeky at school now. I'm always in trouble. I say exactly what I think. I'm not hiding anymore. And I love the new me. Her parents are going, oh my goodness me, my child's always in trouble. But she loved it. She loved this disinhibition she'd got. So sometimes it's a case of actually celebrating the new child as well as mourning the bits that you've lost and finding the positives in there, because it doesn't have to be all doom and gloom. And we need to find things our families can celebrate as well as supporting them to mourn the bits that they've lost.
Thanks for that frank assessment, Jo, and those examples you give, I think, really bring some of the issues to life. Kay, your thoughts on challenges before we move on to maybe some of the solutions.
Yeah, sure. So for me, particularly, the challenge is speaking more from my clinical practice. A challenge for me is driving that change. So what we are trying to do as a team of professionals, quite often involved with children with acquired brain injury, is kind of driving that change. Things have changed. Their life is different from what it used to before, and we know that after a neurological insult, the brain reverts back to the primitive stages of development. So suddenly you've lost a child who has been doing everything to very non-functional, probably wheelchair bound or not able to mobilize, and all other host of problems. Now, when we step in a case like this, what we're looking at is, of course, assessment and the recommendations. We are experts in doing that, but actually making those recommendations happen on the ground is the biggest challenge for me. Is Jo mentioned, the families are overwhelmed. There's so much going on. There are multidisciplinary team, the professionals coming in, and there are a list of recommendations which the family got to prioritize, almost in a state of dilemma of whether I really do trust that these interventions need to happen, and how is that going to happen in the day-to-day life in school. Again, a whole host of difficulties within school because of funding issues. A lot of these children, we apply for education, health and care assessments, and depending on what the funding level of that local authority is, quite often they are not accepted. So then you have a child without the funding within the educational setting, and this child, for example, need multiple change in posture through the day. They need access to equipment through the day. They might need certain therapeutic procedures during the day. Who is going to carry them out, because the school haven't got funding? Not that they're not willing to help, of course they are, but there's no funding. Who is going to do that? Teaching staff cannot, because they've got all the pupil in the classroom. It got to be from a teaching assistant who is designated for this child. So that's a challenge within the school setting. And then the home setting, I quite often feel the difficulty particularly is implementing a procedure or an equipment. Quite often, children who have very profound complex needs, they need strict postural management plan, which requires them to be in a certain position so that they don't deteriorate over the time of their growth and development, whether it's a sleep system, whether it's a standing frame, whether it's a positioning during the daytime. And they are very, very specific and robust if you want that child to thrive. Families find it extremely hard because there will be some level of resentment from the child themselves, because these postures or these interventions that we're wanting to bring in is different from what their bodies are asking them to do, because bodies is under the influence of an injury. So they present in a certain presentations, and we're trying to shift it to the more aligned and a normal way of functioning. So there is a lot of dilemmas that goes on between the families thinking, let's do it the easier way. Why are we bothering ourselves so much? But then again, our role come in play where we're going to develop that awareness in this. What is the consequence if we didn't follow those procedures? What are how this child might look like in 5 years down the line if you didn't have a sleep system in place? Well, they might have hip dislocation, they might have scoliosis, the life expectation might be limited. I mean, the consequences are profound often, but as Joe mentioned as well, that families are not equipped Jan, not Joe. They are not equipped with all that information. We professionals, we know that, but families don't. So there is certainly a need to drive that change and make sure that we're making that awareness across, whether it's school, whether it's families, everybody working with that child is really important. And I always say that every communication that we do got to lead to a change. Change is most important.
Thanks, Kay. Well, let's talk about some of those changes. I think it was really important to spend a bit of time talking about the challenges. If we could now talk a little bit about new approaches, treatments, ways of communicating, those things both externally and that are being developed with reference to innovation that promise even better outcomes for the future. I'm not going to go around the panel. I'd just ask, panelists to come in. If you can indicate you've got something to say. Can we talk about developments that you think hold promise for all those, both families and individuals suffering with brain injuries for the future? Jan?
I think what isn't done enough in this country is cognitive stimulation therapy. Everything is talked about, speech and language therapy, OT, physiotherapy, solving those kinds of problems. The biggest impact on a child's life is poor cognitive function, and nobody deals with that. Nobody deals with improving memory, improving attention, improving even communication skills. And these are the things that are essential to a child's life and a child's developing brain. And I agree with Kay when she was talking about there's a lot of issues around child development that have to be factored in to where any child is. But what we see, the biggest impact to a child being able to manage their life in the future is better cognitive skills. It goes beyond physio and OT and speech and language therapy. They have to be able to make decisions. They have to be able to manage money. They have to be able to tell the time. So it's looking at what we do is we look at beyond the physio and the OT and the speech and language therapy. There's an awful lot of children have aphasia. There's no treatment for aphasia, or very little in this country. So a university in America very kindly shared their program with us, and we'll do that with the kids. When it comes to technology, everything has to be personalized to the needs of that child. And a lot of the time, a lot of the needs are not even identified. So we look at, and one of the things I wanted to do with Matrix is understand why things weren't working, understand why we have so many children in prison, why we have so many homeless, what is going wrong with the system. And I've been part of this system, and I know the bits that even though my son had a neuropsychological assessment, nobody dealt with those issues, only me. Now, when his consultants were saying to me, you have done an incredible job, Jan, because if you'd left it to us, you wouldn't have anywhere near what you have in your son. That's quite shocking in the 21st century. And my son's accident was 13 years ago. His prognosis was he was going to have no quality of life. 2 degrees later, he's employed and working, and his cognitive function, yes, is still a little bit impaired, but he's recovered enough to be able to work. And it is that is driving a lot of parents towards us, because what they're now saying is, I want my child to have the same chances that your child has, and that's what we provide for them. So for me, there is not enough done on cognition and regaining lost or impaired skills or abilities.
So a lot of the children I have through the private sector, just answering some of the things that Jan was speaking about then, we are seeing more now. And again, I can't speak to, I'm sorry that that's happened to you in your position, Jan. There are a number of children who I work with who we're focusing in quite a lot around those focused speech and language about communication. We have some very good work that goes on with my company, getting people into employment, working with the employers to give them extra breaks, to give them communication strategies, to make sure that they are in a position where they can go out and work, often on very much reduced hours. We have a young lady who got herself a job in Costa Coffee recently, and we've negotiated reduced hours. We negotiated things around specific assistance for her to remember the orders that were taken, and she had some very specific things put in place for her to enable her to work. And I think in some cases that's becoming increasingly better facilitated, and it needs to be better facilitated across the board, because it is those important things like that that get young people their sense of purpose, that keep them on the straight and narrow, that keep them out of the areas and the groups that they may fall into. If they haven't got the work and the employment, they can then fall into groups where they get into trouble and end up in the criminal justice system and so on. So there is a lot of work going on around communication, around word remembering, around processing of systems and how you do in the order that you do things to try and address those very issues. So I'm seeing a lot more of that going on now, which I think is really encouraging.
Thanks, Joe. Emily.
Yeah, and I would agree with both. I work, like I say, primarily in the NHS. I do some sort of private work as well, where I do see kind of how case management works and how litigation cases are kind of put together. And I think you're right, Jan. There's a huge lack of neuropsychology support. That's an ongoing level of support. There's often services that will, within the NHS, do assessments, and that's very valuable for a moment in time. But we need to be thinking about how that's kind of, supported in the longer term. And we need neuropsychology to have that long-term approach and to be seeing children at transitions, to be able to be engaging regularly with those children and do proper cognitive rehab with them accordingly. And that just is not commissioned at the moment in the NHS. We have got the CCPNR in Cambridge, which is a community neuropsychological rehab centre, which is excellent and provides brilliant kind of follow-up and rehab for young people. But it's the only one in the country. So, this is very much a work in progress. And I feel very strongly that people need to be saying these children deserve more. They should be having ongoing input from a multidisciplinary team, and certainly from neuropsychology kind of moving forwards. In the private sector, that is different. And I think a lot of case managers are employing neuropsychologists, educational psychologists, SLTs who can look at that cognitive communication, the ongoing cognitive needs and so on. And I think that's really essential within those kind of teams within litigation cases. And I hope that as we go forwards, that's going to improve for the NHS. But at the moment, it just isn't commissioned as much as it should be.
Thanks, Emily. I'm going to bring in Carmel and then I'll come back to Jan. Carmel?
Yeah, I think, picking up on Emily's point there, one of the long-lasting challenges is this kind of postcode lottery that we see across the country in terms of what is available for children and young people in their recovery and rehabilitation post brain injury. And I don't want to sort of dismiss that, but I do want to kind of give a shout out to all of the really important work that the charitable and voluntary sector do to plug some of those gaps, particularly for families who don't have recourse to litigation. and who will be forever reliant on statutory services. And it's easy to paint quite a bleak picture. And I think, we've already on this call identified a lot of the challenges, but there are some real gems of fantastic practice and some, examples of ambitious and creative approaches that are being taken across the country. Both in kind of the formal settings around education and social care, but also, as I said, in those charitable sectors charitable sector services who are delivering so much on the ground. And I think in some ways, having that status gives a little bit more freedom at times to be able to sort of throw off the shackles of being, within the NHS or being in a particular field of expertise. So it allows people to really kind of blow the lid off it and get creative. And, last year, Owen Mitchell hosted our paediatric conference, and we focused very much on those different approaches to rehab. And we saw there, such a wide range of things being delivered on the ground, from music interventions, from forest schools, DJing activities, equine therapy, lots of animal assisted therapies, magic. There was so much going on that I think is kind of not necessarily available nationwide, but those are the things perhaps where we've got opportunities to bring those more into the mainstream. And the other point that I just wanted to make was going back to the point about technologies. And whilst I accept that for lots of young people, they do need more bespoke packages, we have to remember that brain injury is a really, really broad spectrum. And what we've seen over the last sort of 10 to 15 years is an influx into the market of technologies, programs, things like Alexa, smartphones, Ring doorbells, mental health apps, cognitive development things that you can have at your fingertips on your phone, which actually are bringing a whole new level of independence for children and to families that wasn't there beforehand. And I think that's something that's really worth celebrating. And of course, it's low cost because it's in the mainstream. So it's kind of, it's also normalizing that, all of us need a bit of extra support in some aspects of our lives, whether it's organising our diary or having a reminder that we need to take our medication at 3:00 in the afternoon. So I think that's a really good step forward.
Fantastic. That's really encouraging, Carmel, to hear about those that are pioneering new approaches and innovations. You gave some great examples there. It's a positive note on which to start to sort of draw the discussion towards a conclusion. And to do that, what I'd really like to do is to go around the panelists and ask each of our panelists just to give us a very short statement, a soundbite, if you like, just those one or two things that you think would make either a fundamental or a really material difference to the future for all those suffering and dealing with brain injuries, but also all those supporting them as well. Those, if you were to pick one or two things that represent your hope for significant change and improvement for the future. And we started with you, Jo, so I'm going to put you on the spot.
Thanks.
Sure, you might say this question is harder for those that come last rather than those that come first. So just your thoughts, those one or two things you'd pick, Jo.
I think the thing that all of our young people have in common is education, and that's where they spend the vast majority of their day. So extra support for and training and resources for those in education, sorting out our EHCP and our SEND systems so that the resources, especially for those that haven't got the benefit of extra resources coming through litigation, the resources for our young people within the education system that can encompass everything from education to physio to speech and language and all the other aspects can actually be available to people, and have teachers who've got the training and the knowledge and the other specialists on hand within the education system, I think would make a massive difference and level the playing field for all of our young people.
Fantastic. Thanks, Joe. Jan, can I come to you next? If you were to pick one thing or one or two things that make a big difference.
I think what the NHS is now recognising is the value of lived experience. And as a parent, when you have rehabilitated your own child because you realised if you didn't do it, no one else was going to, that's really powerful for parents. So it's valuing the lived experience cohort of people and making things less clinical and less professional led. Our neuro rehab team are actually a very experienced SEN team. So Emily, I would say neuropsychologists are not actually needed to do cognitive neuro rehab with kids. You can do it. It's about understanding what it is you're trying to achieve. So I think lived experience, I think making things less clinical because you cannot make things clinical in school. And we do acquire EHCPs for children. And we do get outcomes, because the other thing with EHCPs is they continuously change the goals and the outcomes when they're not met. And that's a big issue as well.
Okay, that's great. Thanks, Jan. Kay, your thoughts, one or two things that you think would make a big difference?
Yeah, thank you. I would say, from my perspective, dealing with children who have acquired brain injury and the families who are going through a lot, just be kinder than necessary. Show the compassion that we're there to care, is the most important thing. And it just really helps validate their emotions that they're going through. So we're there to support, but that extra level of compassion is what is required for these families and these children. Thank you.
Brilliant. Thanks, Kay. Emily, same question.
From my perspective, I think working together is what comes at the centre of it all. We've recently set up a young people's advisory group for Enables, and our young people are incredible. The ideas they have, the insight, and like you say, that lived experience, Jan, is just so crucial. And I think being able to co-produce our sort of service planning, our interventions, our kind of innovations with young people, with families, is really essential going forwards. And it's definitely becoming more part of what we're doing in the NHS. There's a drive for that to be happening. And I think it should be happening across the board. So that's really important. But within that, I think it is crucial that we haven't just got pockets of good practice. And Jan, it sounds like your group do an incredible job. I hope that that's all kind of evidence-led and so on. And, it's brilliant that that's happening. But it
absolutely is. Yeah,
it's a good practice. And I think we need to be working as a system to make sure these pathways exist for every child and that everyone has access to good support, rather than it just being that there's an individual who's making a difference in one bit of the country. So that would be my opinion.
Great, thanks, Emily. And listening to the diversity of views and some of the things we've talked about, that seems a really important message. Everybody involved in this area working together and sharing good practice and experience. Carmel, you get the final word.
Oh, wow. I feel like I've got a heavy burden to carry. For me, I think it's really important as a team of professionals that we continue to work to dispel this myth that kids bounce back after ABI, regardless of where they might be on that spectrum, or that kids, do really well after brain injury. We need to keep banging that drum to explain that the ABI it's very complex, it's a very individualized experience, and it can have lifelong and life-changing consequences, and that's why it needs to have its own recognized pathway, clinical pathway that is supported by all of the professions represented here and beyond, and that support is maintained throughout that child's lifetime, because children become adults And what we do is going to impact on their outcomes in adult life and what they can achieve. And my final word is that we need to be brave and bold when it comes to planning rehab and thinking about ongoing recovery from brain injury. And don't, always ask, why not? What can we do differently? How can we, look for different solutions? How can we drive innovation? How can we affect change for the families that we're supporting?
That's a really positive note in which to conclude this wide-ranging discussion. On behalf of NR Times, I'd like to thank our sponsor, Irwin Mitchell, again. But a massive thank you to all of our panellists who have been so generous with their time, with their experience, and with their insight. I'm sure we'll come back to touch on this subject and maybe some of the elements of the discussions we've had today. For all those that are watching, our panellists, everybody involved, when this clip's available and this discussion is available on the NR Times platform and on YouTube, please share it as widely as possible. We know thousands and thousands of people are watching these discussions, and this discussion certainly deserves to be seen by as many people as possible. So thanks again to Irwin Mitchell. Thanks to all of our panelists, and enjoy the rest of your day. Thank you.